All right, let's jump straight into this explainer on the algorithmic matrix for esophageal, gastric, hepatobiliary, and pancreatic pathologies. We're kicking things off with Module 1, esophageal dysmotility and transmural disruption metrics.
Take a look at the rigid contrast between these two major motility disorders. On the left, we've got achalasia. Basically, this is a failure of the lower esophageal sphincter to relax, and it's driven by the degeneration of the myenteric or Auerbach plexus. These patients are going to come in with progressive dysphagia to both solids and liquids. You can clearly see that sharply tapered bird's beak narrowing on the barium swallow. But, and this is absolutely crucial, what's the gold standard diagnostic? It's esophageal manometry, which will explicitly show increased resting pressure and incomplete relaxation of that sphincter. Now, contrast that with diffuse esophageal spasm, or DES, over on the right. This presents with uncoordinated contractions that literally mimic a myocardial infarction, and it's often triggered by drinking cold liquids. The barium swallow shows this really classic corkscrew pattern, and if you look at the manometry, you'll see high-amplitude, simultaneous, uncoordinated waves.
Okay, let's move to transmural disruptions. You've got to strictly differentiate Mallory-Weiss tears from Boerhaave syndrome. A Mallory-Weiss tear is just a superficial mucosal laceration right at the gastroesophageal junction. It usually follows severe retching and presents with self-limiting hematemesis. Fun fact, though, Herman Boerhaave originally discovered this next syndrome way back in the 1700s after a Dutch admiral ate way too much, vomited violently, and literally ruptured his esophagus. So, Boerhaave syndrome is an entirely different beast. We are talking about a full-thickness transmural esophageal rupture. The presentation is severe retrosternal chest pain, subcutaneous emphysema, which you're going to palpate as crepitus, and a pneumomediastinum. Make no mistake, this is a surgical emergency. The absolute requirement for diagnosis here is an immediate water-soluble gastrographin contrast swallow.
Now let's see how a clinical vignette forces your diagnostic pathway. We have an alcoholic patient presenting with severe retrosternal chest pain and chest wall crepitus after violent vomiting. You literally have to recognize this pattern instantly. Severe vomiting followed by crepitus equals Boerhaave syndrome until proven otherwise. So, what exactly is the next best diagnostic step?
Here are the traps you absolutely must avoid on the boards. Selecting an upper endoscopy, that is a huge trap because the air insufflation will actively exacerbate the rupture. Selecting a barium swallow, that's a lethal trap. If barium leaks through that transmural defect, it causes a severe, catastrophic mediastinitis. The only correct diagnostic selection here is the gastrographin swallow. It's safe, and it perfectly detects the transmural rupture.
Moving further down the GI tract, we're into Module 2, gastroduodenal ulceration and malignant branches. Dissecting peptic ulcer disease requires a rigid distinction based on symptom timing and, of course, malignant potential. Gastric ulcers typically cause pain that worsens immediately with food. And because gastric ulcers carry a really high risk for malignant conversion to adenocarcinoma, they require a mandatory surveillance biopsy, no exceptions. Duodenal ulcers, on the other hand, typically cause pain that actually improves with food. They're overwhelmingly driven by H. pylori infections or NSAID use, and they carry a very low malignant risk. So the crucial point here is exactly how you test for that H. pylori eradication. You can't just test the patient while they're on their medication. You've got to enforce a strict timeline. At week 0, you completely stop all proton pump inhibitors. You then require a mandatory 2 to 4 week washout period. It's only post-washout that you can accurately perform a urea breath test or a stool antigen test. Now, if a patient has multiple recurrent and refractory ulcers extending far past the duodenum and all the way into the jejunum, you need to isolate Zelinger-Ellison syndrome, also known as a gastronoma. The diagnostic milestone for this, vastly elevated fasting serum gastrin levels. We're talking usually greater than 1,000 picograms per milliliter. To confirm it, you use a secretin stimulation test. And here's the really surprising paradox. Normally, secretin inhibits gastrin release. But in Zelinger-Ellison, secretin actually spikes the gastrin levels. Wild, right? Okay, let's test a major cognitive trap. A patient with chronic abdominal pain on ongoing PPI therapy has a negative H. pylori urea breath test, but persistent symptoms. They're simply not getting better. What cognitive error is present in this trekking loop? The error here is trusting the test while the patient is still on active acid suppression. Ongoing PPI therapy universally invalidates H. pylori clearance testing. Why? Because it suppresses the bacteria just enough to cause a false negative urea breath test. You cannot assume ulcer refractoriness without a valid eradication confirmation, and that absolutely requires that 2 to 4 week washout period we just talked about. Shifting over to the accessory organs now, let's hit Module 3, hepatobiliary inflammatory tree and obstruction pathways.
Let's map this out and see how this builds a rigid comparative matrix of the biliary tree. Look at the progression here. First, cholelithiasis. The stone is just sitting in the gallbladder, the patient is totally asymptomatic, so we manage it conservatively. Next, cholecystitis. The stone obstructs the cystic duct, causing gallbladder inflammation. Now you get constant right upper quadrant pain, fever, leukocytosis, and a positive Murphy sign on exam. You'll want to confirm that with an ultrasound or a HEDA scan. Then, cholelithialysis. The stone drops down into the common bile duct. Now you've got right upper quadrant pain and elevated bilirubin causing jaundice, but strictly no fever.
But what exactly happens when bacteria infect the static bile sitting behind that common bile duct obstruction? You get ascending cholangitis. This is a catastrophic bacterial infection characterized by Charcot's triad: fever, right upper quadrant pain, and jaundice. And if it progresses to shock, you'll see Reynolds pentad, which adds altered mental status and hypotension to the mix. The absolute required next best step here is immediate ERCP for biliary decompression along with IV antibiotics.
Let's lock this concept in. A jaundiced patient with a known common bile duct stone suddenly develops a fever of 103 degrees Fahrenheit and drops their blood pressure to 85/50. What is the immediate next best step? This scenario highlights the razor-thin difference between a normal elective workflow and a crashing emergency. An elective laparoscopic cholecystectomy? That's a trap. The patient will die from sepsis way before you decompress the common bile duct. Getting an abdominal CT scan is also a lethal trap. You already have the clinical diagnosis of Reynolds pentad right there in front of you, and sending an unstable patient to the CT scanner just delays emergent therapeutic intervention. Urgent ERCP for biliary decompression is quite literally the only life-saving answer.
And finally, we've arrived at Module 4, pancreatic pathologies and accelerated pattern recognition.
Acute pancreatitis is essentially the parenchymal autodigestion of the pancreas. To nail this diagnosis, you strictly need 2 out of these 3 criteria: severe epigastric pain radiating to the back, a serum lipase or amylase level at least 3 times the upper limit of normal, or characteristic CT findings. You also have to keep track of the timeline for complications. For example, a pancreatic pseudocyst will present as a persistent amylase elevation 2 to 3 weeks after the initial flare. Transitioning over to malignancy, pancreatic adenocarcinoma presents with some very specific physical exam findings. Look out for migratory thrombophlebitis, which is known as the Trousseau sign. And because tumors in the head of the pancreas physically compress the biliary tree, you're going to see painless jaundice and a palpable non-tender gallbladder. That's the Courvoisier sign. The diagnostic image of choice to confirm this? For sure, it's a CT scan of the abdomen. Okay, let's pull all these modules together into an accelerated pattern recognition block, cataloging the major cognitive errors. Do not delay an emergency ERCP in ascending cholangitis just to obtain an abdominal CT scan. Do not perform an immediate contrast CT for uncomplicated acute pancreatitis within the first 12 hours. The diagnosis is clinical and enzymatic, and the scan simply won't change your management yet. Do not perform H. pylori breath testing without stopping PPIs first. And never, ever use barium contrast in suspected Boerhaave syndrome.
So, the absolutely crucial takeaway is this. In a crashing patient with gastrointestinal pathology, what single cognitive bias leads to the highest mortality on the boards? It is the deadly urge to delay an immediate life-saving therapeutic intervention just to obtain unnecessary diagnostic imaging. When the clinical picture paints a mechanical obstruction or a transmural rupture, trust your criteria, avoid the imaging traps, and decompress the system immediately.